All right, good afternoon. Welcome. It is December the 1st. The year is almost over. It's THCB Gang. I'm Matthew Holt, founder, publisher, currently patient. And we'll hear a bit more about that in the show. And sitting here having watched a lot of the World Cup. And did you know Japan just beat Spain and go through, and the Germans go home? And for one brief moment of the games today, it was like Costa Rica might go through and Spain and Germany might go out. But there you go. So the World Cup's been ruining my life. Who do I have to reinstate and talk about healthcare? Kim Bellard, regular THCB contributor, Jeff Goldsmith from Health Futures Inc., Michael Millenson, Health Quality Advisors, Casey Quinlan, delighted to have Casey back from Health Growth Hilarious podcast, and Jen Goldssack, who I've now decided not going to have a special guest anymore. She's just one of the gang. So anyway, so I guess welcome to being in the gang, Jen, and welcome everybody else. All right, fantastic. And then, so let's do a quick go around and let's start. Casey, can I quick go around with you? How are you doing?
Sure, I'm fine. I mean, this is a new look. This is,
I like it.
Is permanent.
You've gone ahead of me.
This is permanent. But it's like hair or stay alone. Do I have hair or death? I would prefer. I'm just going to stick around. So no hair thing is totally a thing now. I mean, I do have a wig. I wear a hat often when I'm out of the house, just because it's like I would rather not attract pity. That's not the point. But I'm saving lots of money on shampoo and hair products. So there's that. But no, I mean, things got interesting with my cancer treatment, and my kidneys were trying to shut down. So we had to switch things around a little bit. So now we're in this mode, but my kidneys are working again and I'm feeling better. So, all in positive. So let's, keep moving.
All right. Fantastic. Well, it's great to hear. I have joined you a bit the last couple of weeks. I've been gone. I was carted off the show floor at HLTH in a wheelchair and have been having some back issues. And what did Jeff just say off the line? I'm no longer a teenager anymore. I can talk a bit about my adventures in American healthcare, which have been fun as ever. And I've been looking particularly at the data around back pain and how non-current and non-good it is compared to the amount of back surgery that gets done. But we can perhaps dive into that. All right, Michael, what have you been up to? What have you been watching?
All good. Looking at what's going on. Do you want us to give you our summary of what we think this week has been, or we're going to wait on that?
No, let's do that.
Well, so I was going to call this week the lame boss and the lame duck. And the lame boss, of course, is Elon Musk, where he's going to allow misinformation on COVID in the name of free speech. Although I think if you're going to do that, you should eat your own cooking. And next time, if you get sick, take Clorox. So, it's all that's our lame boss who's doing all sorts of other things that are even worse than that. And of course, the lame duck is Congress, which before the Republicans take over and the Clorox caucus, as it were, starts doing healthcare, we can see whether we extend waivers for home care, telehealth, and various other kinds of things. So this is our lame duck and lame boss. I'm not sure which group will have more impact on us in healthcare.
We'll find out. Kim.
So my wife has just spent the last several days in the hospital with RSV. And if you're not taking RSV seriously, take it seriously. It's a big deal. But what struck us both was almost all of the nurses she had over the several days were traveling nurses. They weren't from other places. They were local people who said, why should I stay an employee of the health system when I can become a traveling nurse and get paid 3-4 times as much as otherwise? And I was thinking, like, even if the health system could afford that, which it can't, obviously, how do you maintain a culture? How do you manage to, the floors? It's just an incredibly dangerous time, I think, to try to figure out how you're supposed to keep the health system going with all these strange permutations.
Absolutely, Jeff.
Yeah, I mean, I'm continuing to watch the huge gap between revenue and expense growth in hospitals and in healthcare in general. Makes me nervous. And the absolute pasting that hospitals and health systems are taking in the press and in the academic world. It's just every week there's another slamming, angry diatribe against this industry. And I've been as much a critic of these places as anybody else, but I think it's really gone overboard.
Wait. Which is overboard? The part about billing poor people, the part about, which exactly would be?
Well, we'll argue about that in a minute. I know where you're going, but there has been a lot of,
honest to God, guys, we don't have a mental health system, so hospitals have to take care of people that are mentally ill. We don't have a long-term care system, so people are stacking up in hospitals because they can't get referred to nursing homes or anywhere else. They can't get out of hospitals because there's nowhere to take them. So then you blame the hospitals for being too expensive.
I would just like it if they wouldn't sue their patients. That'd be a small thing they could do.
I'm with you. I'm totally with you.
We're not going to have the fight that we could have about that till later, because poor Jen now she's biting down on the pencil because she wants to. But
you just bit the pencil in two.
She bit. All right, unbite the pencil, Jen. Tell us that digital health is saving it all. Tell us something.
I think Jeff and everyone, the points are well taken. And what occurs to me right now are these sort of juxtapositions and where different stakeholders in the industry are. So Jeff, we reflect on that pain, and then we look at Q3 earnings from our payer colleagues, right? And I think we're starting to see the same thing in digital. The absolute absence of something like a mental health system of sort of any maturity whatsoever could very well be served by digital solutions, virtual first care, all of these different sorts of things. But the challenge and what's frustrating me right now is the sort of messaging that you're seeing in some of the really strong and really successful organizations coming through, the doom and gloom, the pressure they're getting from investors, tighten your belt, lock it down, it's going to be dark, they're going to fail, all of this kind of thing. There's a phrase I like, the cream will rise. And I think there are going to be organizations that shake out in the upcoming economic headwinds. Do I think those headwinds, in my opinion, are going to be catastrophic? No. And do I think we absolutely want to pump the brakes on any investment in innovation in the digital space? Absolutely not. And I find it an alarmist perspective. And when we do have this enormous need, just like you described in the more sort of traditional healthcare delivery environments, we should be supporting those high value solutions, not across the board telling them to pump the brakes.
Well, we really need 12,000 digital health companies. Really? Isn't a part of the problem the fact that there's way too much capacity in the system for what's needed?
So I ran the numbers on I should be in Japan because of my back, I'm not. So this week I'd normally be at the what was Health 2.0 Japan, it's now called Health Tech Some Japan. I will be briefly on their Zoom yesterday, but I ran the numbers again just to look at it, and we're at about now Q3 of 2022. At the end of Q3, we're at about where we were for the whole of 2021. Sorry, 2020. 2021 was this crazy year with almost free interest rates and unlimited amounts of money, and Tiger Global writing, $100 million checks every other week to any company that moved. And obviously we had massive stock market correction, although it seems to be picking up again, and who knows where that's going to head. But we're still putting a lot of money into this, and you're still seeing a lot of people trying different things. There's still a lot of capital around. And I'm with you, Jeff. There are too many companies. There are enough established companies. There isn't enough this and that and the other. It's still not clear to me as to where. When you have hospitals with a traditional business, as described by Kim, paying those travel nurses X times the amount they should be and having labor costs go through the roof in a way that, clearly reimbursement payment is not catching up with in their traditional business, and having to deal with the fact that everyone's burned out from COVID, and having the real fact that COVID is not over and there's RSV and God knows what else hitting them compared to all the other stuff they have to do. You have that. It's still unclear to me as to where the hospitals, big hospitals, health systems, whatever you want to call them, the big incumbent players in that space are going to, are figuring out how to work with the right digital health companies to do the kind of stuff that Jen's talking about, or whether they're going to be taking this. And I go back, we'll bring it up again. I go back to the Amazon example. It looked like Amazon was going to try and do a virtual first play across the country, and then gave up and said, we'll buy the tiniest primary care toniest, upper echelon primary care doctor there is out there, and then we'll have a weird marketplace for, for dick pills and hair pills or whatever. So I think that we can go to that. I do want to raise one thing that you may or may not have seen this week. There's an amazing article which just like freaked me out in both in the New York and ProPublica by Ava Kaufman, which is on hospice care. If you haven't read that, that is amazing as to how,
disgusting.
Private equity sort of took over what should have been a great benefit given to the Medicare system, and has played it. And you look at that, Jeff. You mentioned the collapse of long-term care and nursing home care, and that also has been plagued by both, pretty dodgy operators before private equity got into it, and now private equity. There's so much going on that needs fixing. I don't know where we start. Anyway.
Well, but just to add to it, and this is actually my little research project for the next 6 weeks or so, the fact that hospitals now employ about a third of the practicing docs in the country. So it isn't just that they've filled the gap in mental health and long-term care. They've also basically propped up a huge chunk of the physician infrastructure in the country. And frankly, a lot of them didn't want to and are losing their butts doing it. Yeah. So, I mean, there's a tremendous amount of hospitals weren't built to do all this stuff. Forget about, whether they're suing people or not. I mean, we have our, the University of Virginia was sued 36,000 people in a county of 115,000. That's clearly that's not a sustainable business model. But neither is the hospital, which was designed to do a certain thing, basically doing everything else in the society because the infrastructure is falling apart. That's not okay either.
Michael.
So I've got a question, and if this group can perhaps help me with my ignorance. I'm trying to figure out, when I see all those announcements about CVS with the primary care and Amazon with primary care and everybody else with primary care, I'm trying to figure out where those doctors are coming from. And I can't figure out whether it's all through the existing system, like, a hospital that has 100 employed doctors, then tells them in your spare time do telehealth for Amazon or CVS or United Healthcare. Where are all these primary docs coming from?
That's the joke. It's not just docs, Mike. It's nurses, advanced practice nurses, and all the rest of it. The whole thing with CVS that started out, with Minute Clinic, 15 years ago. It was it wasn't doc in the box. It was a nurse in the broom closet.
Right.
And so what a lot of these companies are doing is they're announcing these huge expansions and then assuming that they can recruit the staff to staff them. And that's the joke, because they can't do it. There's not enough clinicians out there to staff all these different models.
That's also about, because I went to a doc in the box thing and they talked about all the nurses that they wanted. And one of the nurse practitioners, one of the nurse practitioners, whatever they were, said, having a nurse who's been doing this for 10 years out there alone is different than having someone who she just got her diploma. Where are all these people coming from?
So there are two things going on here, right? So one is there's a whole ton of acquisition. So the two big, three acquisition monsters in the retail. Walgreens has bought over the HMD and adding, they are growing by acquisition, but also by more people. Optum has primarily been buying other already existing medical groups.
Right.
And CVS has been growing, just, paid a lot of money for Summit and CityMD in New York City, right? And the New Jersey area. So the thing that worries me, I wonder, right? And then Walmart has all these plans. In fact, I was at HLTH, I was moderating a session with Cheryl Pegas from Walmart and Sachin Jain from Scan. And I said to her, Walmart keeps on, chopping and changing what it does. How can we trust you to say you're going to open 100 centers and do all this great stuff in rural America? And Sachin said, that was all those people before Cheryl. Cheryl's here. It's all going to be great. And then at the end of the week, Cheryl announced that she was quitting and going to going to become a venture capitalist. But there is this acquisition thing, but as you said, there is, there's this lack of doctors. And one of the things Cheryl said on stage was roughly 300,000, I don't know where she got data this from, 300,000 healthcare workers have left the profession, and nearly 100,000 of those are physicians. I don't know if it was MPs.
That number is completely bogus.
It is?
Let's just get rid of that number right now.
So what is the right number?
There's only 900,000 docs and 117,000 of them quit last year. Let's not even talk about this stuff. I don't know where these data come from, but they're garbage.
Okay, so we don't say 117,000 of them left?
Yeah, that's what they said. Last year, 117,000 left. Rubbish.
Okay. I'll take it rubbish. Is that wasn't Kaufman Hall or somebody who came out with that? I mean,
no, it was definitive healthcare. And for the life of me, I can't understand where their data comes from.
Well, there's always been a big gap between how many licensed physicians there are in the country and how many practicing physicians there are in the country. Well, I think it depends on which number you're using as your base.
There's about a million. There's about a million licensed physicians and maybe 900,000 practitioners, and 117,000 of them didn't quit last year.
Okay,
I'm just telling you.
Do we think so? But on the other hand, they're still growing at a rate that is not. There are two things. That, as go back to my
17,000 a year are entering the profession,
but at a slightly lower number, but not that much lower, are leaving, retiring. Just
a larger number are retiring. But there's a shortage of docs.
There is, but I mean,
where all of these people that want to expand their primary care are going to get the docs from is a really
well. There's certainly a shortage, as there's always been a shortage of primary care docs, right?
Exactly.
But there's also a shortage of cardiologists. There's a shortage of gastroenterologists. There's a shortage of rheumatologists. There's a shortage of I mean, you name it, and there's a shortage of it.
Get an appointment with a dermatologist. See how long that takes you.
Yep.
All right. So Jen, how do 12,000 digital health companies fix this by scaling the one dermatologist they have on staff? I'm kind of kidding, but if we can't use digital health to do that,
yeah.
This is exactly right. The whole purpose, what we have to be focused on for the problems that digital needs to solve, is how can we extend every unit of clinical expertise that we have in the country? And back to the really good pointed question about where the heck are all these primary care providers coming from? I actually think that what is intended by the statement of, we're going to start providing primary care is we are going to provide primary care services. And I think that only some of that is mediated by a clinician. I think we have to look at the thoughtful use of things like navigators. And that is what I believe is going to underpin a lot of the model. That's not a magic wand to say, and by the way, we also have enough clinicians. I think that is going to be the thing that keeps any health executive up at night, whether you are the chief medical officer of a virtual first care provider, whether you are a chief nursing officer at a traditional brick and mortar facility. There are not enough clinicians. But when we hear about these enormous primary care models expanding, I think it's much more about primary care services, the whole bundle of being responsive, being able to triage to the most appropriate care, to have someone there when you need it, recognizing that healthcare, especially things like mental health, are not 9 to 5, Monday to Friday. That's the model that they're driving towards, Jeff. And as I said, it doesn't explain away the clinician shortage, but I think that's the strategy.
Well, but the question I want to push back on you a little bit, Jen, is, and remember, I'm a believer in digital health. I'm an investor in digital health. So this is not skepticism on my part about the value or the leverage. But I'm looking for evidence that digital health has made primary care more productive. Where is it? Where's the evidence?
The side crickets.
Well, I'd say not yet. I'd say that the transfer that we've seen so far has been low-level telehealth. Now, I think you can argue that there are some digital health organizations, digital virtual first organizations, which have fixed the waiting list problem. So speaking as a guy who has got access to One Medical for a bunch of stuff in the last week on their telehealth service, whatever, that and that bit they don't bill for, right? I can talk to a doctor on their service without billing for it. And unlike Cleveland Clinic, who are about to charge you for answering messages on my chart, right?
Right. That blew me away.
I mean, so you can see areas where it's made a difference at the margin there. What we haven't done, and I saw some tech in health, I've seen tech like this over the years, as have all of us, is what we haven't done is figured out how to really help the clinician in their day-to-day practice squeeze
workflow.
Exactly.
So, for example, I saw a very clever and I'm blanking on the name of the company from Israel, which had built a very clever chatbot, which basically took the history and, went back and forth with the patient, presented the history in a very nice way for the doctor. And they said, take 6 minutes out of every primary care visit. And, many of the grey beards on the phone, well, they're not with a grey beard because they're with a beard. I don't know, Michael's got one too, sorry. We'll remember there was a company called Instant Medical History, which did something similar and was going back in the late 90s, early 2000s, and somehow never caught on to, can we take that history and, take it out of the visit and give it so the clinician doesn't have to deal with that.
Yeah.
So, to me, it's always the issue. We've got these clever technologies that potentially could help in scaling. Can you somehow integrate them into the care process?
But Matthew, even there, that history is the opening piece of the dialogue between a doctor and a patient. It's the way in which a physician gets to know the patient and gets to understand, what is this person presenting to us? How do they really feel? What's really driving their condition? And it's not about the data.
I've genuine question, and I'll give you an example. I live in Florida. It's not even like there's a 3-month waiting list. There is no primary care physician who's taking anyone down yet. There isn't one. It doesn't exist. So let's also have some real talk about what current state is. So we have, Blue Cross Blue Shield of Florida, and do I use their phone-in service when I need to? Yes. Is it great? No. But it's either that or I go to the emergency room or urgent care. Right? I have to do pre-op for an ortho surgery. I could go I'm literally going to have to go to urgent care. It's ridiculous. Right. So let's have some real talk about what current baseline is when we say, where's the evidence that sort of digital has done anything to improve primary care? I also think while the tip of the spear was doing virtual was doing telehealth, and I'm going to use 2 words very intentionally, and I think that this is important, that we were doing some level of telehealth pre-pandemic. Sure. What we've seen emerge is a much more holistic and integrated set of services from newcomers and incumbents that really is thinking about less, can we bolt on a Zoom call and do what we would have done in the clinic anyway, and fundamentally reimagining what it is to care for people, not obfuscating the role of the human and the clinician. And I separate those 2 things intentionally because, Jeff, I absolutely, there are things you don't see in the data. There are things you have to hear. But the reality is, if we hold on to a model where we're expecting, you gave us the numbers, the clinicians to have time to have those conversations, we are just going to get increasingly backed into a corner. We have to think about, we have to figure out how to pay for team-based care. We have to figure out how to do all of these things substantially better.
Yep. I mean, go ahead, Kim.
Well, every time I hear, we need more clinicians, I think about 1960s or 1970s U.S. manufacturers. We got to throw more bodies at that. Well, no. The thing that, we are producing more things in American manufacturing than ever before with far fewer workers because they redesigned the factory. We have not redesigned the factory. We're not even wanting to touch redefining the factory. Again, my wife was in the hospital. 90% of the time she was there was just waiting. Nothing was happening. Yep. The concept of just in time, getting things delivered at the right time, at the right place, the right person, that does not happen in healthcare. And until we do that, we're never going to have enough people.
Yeah, I'm with you.
Yeah.
All right, Michael, then Casey.
So explain me, and as you were describing it, I was thinking here, I'm in the Chicago area, right? A North Shore Health System followed suit to Cleveland Clinic, charging for the messages, anything that's medical advice, as opposed to what? You're writing your doctor to say, what's the weather tomorrow? But where I'm still struggling is that I think they've discontinued some telehealth visits from North Shore because they're throwing them at patients that are there. If you have the same number of primary care physicians and you're not going to more of the NPs and people like that, how will all these additions create the efficiencies that Kim is talking about? And when I look at the press releases, I don't see anything that, maybe I'm missing something here, but I don't see where the extra efficiencies are. I just sort of see people who are looking at, $4 trillion and wanting to move in it. But Jeff, maybe you can see the efficiencies that I don't.
I mean, I think the big winner in the whole telehealth thing has been the patient and the family, because they haven't had to go and sit in a crowded waiting room.
Oh,
They can
absolutely.
access people from home. So, I mean, I think the real benefits have been to us rather
Right.
than to the clinicians.
Right.
And
All right,
I think we're
let
just
me
beginning
throw in
of
one.
learning how to do that.
Let me throw in one thing here. Sorry, Casey, and then I have something to throw in. Casey?
Well, the thing that I've been sitting with and thinking about for a long time, but particularly over the last few weeks, because there have been, so many compass points where, it's sort of, the world seems to be running on what it thought it was, they thought they were making things, but it was all just really vaporware. Just the challenge of trying to retool healthcare using, tech-enabled consumerization, all this, stuff that I've been hearing for, we've all been hearing for the last like 20 odd years, is that, tech is going to solve healthcare and everything's going to be easier, and the Amazonification or the Uber of health. I'm not 100% sure. I do not have the answer for how this industry has become, or has, just historically been so resistant to any change that would actually introduce efficiencies. But then, we have this other conundrum where the entire tech bubble or, tech vision seems to be basically effed up. If you look at, sort of late stage surveillance capitalism as the current model that is, driving much of the economy, how does that help healthcare in ways that aren't creepy? It doesn't. And I mean, we're at an inflection point right now, and I'm not sure where things are going to go, but it's all tied together. And it's, the trust issue, because tech has turned into such a toxic soup of basically underwear sniffing, if, left to its own devices. There's a lot of trust issue here that the, clinician side, lack of trust, patient side, lack of trust, just a lot of lack of trust. And once you get to, to that point of view or to that stasis, you're not going to be able to change anything. And growth hacking, as fun as it sounded while it was still working out there, as people were, sucking up venture capital and building, platform and platform. Now that that's, been demonstrated to at least now be vaporware, where are we and where do we go from here? That's it. I'm not sure healthcare can look to tech for.
Let me say a couple of things about that, Casey, because we have, when we have you'll see the guy Sam SBF, big.
Oh God, yeah.
Yesterday, and they say, "Could you please applaud for this guy as he stole $1 billion?"
I think that we need to call it an SBF scheme now, not a Ponzi scheme. Yeah. I think it's going to be an SBF. Scheme.
Come on, Casey. Who among us hasn't taken in $10 billion, taken a couple of billion for their own purposes, and traded it away and found there was?
I know, right?
Oh, all right. But I mean, but other than that, I think that there is. Yes, there is skepticism on both sides, right? That tech was going to come in and provide a big answer. Yes, there is still panic and skepticism and concern about clinicians, but I think there's still a decent amount of trust there. And we should get into and so I'm going to start talking about me because unlike me. But so for my recent experience, right, is that there are a couple of things going on that I don't know. So I have this new back issue, and it is we can talk about consumerization. What it is it's consumer self-directed, right? Because I have a chiropractor, I have a primary care doc. The primary care doc is not a capitated primary care doc who manages my entire care. He suggests stuff, and I call into, and he says, "Oh, call the emergency line, and somebody there will prescribe you the whatever." That's an email back and forth with him. But then, then it's like I go to the emergency room and they say, "Oh, we've made a referral to this doctor." So they write the doctor's name in the note, which they give me, and then I can look it up online. Don't bother telling me his phone number or anything, so I have to go searching around for that, and eventually and then I get in the UCSF, greatest hospital known to mankind in the West Coast. Well, you can argue the East Coast, but anyway, always top of the list, has US News and World Report, whatever. Get in their phone tree, and when I call the number for this doctor, of course I'm in a phone tree, and the question is, do you want ortho or do you want neuro? Well, I'm a back surgery. I know orthos and neuros both do it. I don't know what I want. Do I know who he is? No. So I'm working through the phone tree. I finally get into a voicemail box that promises to call me back within 2 days, and then I call it back. On the other hand, but I mean, that's where we are, right? There's no way of accessing it. I can ask for an appointment in my chart, which is the system that, we spent $35 billion of the taxpayers' money setting up for UCSF. I can only ask for an appointment if I want a COVID test or if I want a vaccination. Nothing else can I ask an appointment for because I don't have a appointment set up or something. So I'm reduced to this level of communication. Then it gets better. My chiropractor says, you want to go and talk to these pain guys over here. They can give you the back shot, whatever. So I call them. They send me they then send me a PDF form. Oh no, sorry, it's a form on their website I can fill in, which, I can ask for a contact. They then use my email to send me a PDF form, which I then have to fill in my email address and my insurance, all the rest of it. I'm going, this is where most of the people I'm dealing with here are using 1980s technology, maybe 1990s technology to be fair, to solve a problem which, Jen and Michael and Jeff, all of us have seen any number of companies in Health 2.0, Health, HIMSS, whatever, who've got solutions to this. It's just not getting into the system.
Right.
And part of the reason is these back surgeons and pain management people are so damn busy and they're so in such short supply. Why should they bother changing?
Right.
Why should they bother when they can put this pressure on the patient? So and I'm still waiting for my calls back from all these people.
Well, you see, this is what Vince's platform was supposed to solve for you. Is it was going to create a trusted source that enables you to navigate through all those choices in some kind of sensible way. And honest to God, I don't see that happening. Tomorrow, I don't see it happening in a year. And I'm not sure. I think this fragmentation is, I hate to say it, but it is a part of the physiology of medicine itself. This isn't a function of it's not the economics. I mean, it's the way people were trained, is that we chopped the person up into all these pieces,
all the little bits and pieces.
Yeah, and we didn't get any. And those bits and pieces never got put back together. And this was the promise of Iora. It's the promise of Oak Street Health. There's a bunch of companies that actually are out there that say they're trying to reintegrate all this stuff. Scan Health. I mean, a holistic model of caring for older people, based on Medicare Advantage, the social HMO. The whole idea was to knit this stuff back together. None of these solutions have scaled.
Right.
And I don't know why that is.
So can Optum, which has now bought a bunch of companies, a bunch of primary care doctors that looked like that, Atrium and others, can they scale it? Can CVS, scale it? Or otherwise, can Glenn Tillman, right? Can Transcarent what's it, Included Health now? What are these navigator companies? Can they have a go at this? Because somebody shouldn't. I kind of feel like it shouldn't be left to me. And then
I'm with you.
At the end of this, I'm going to rant about data, but let's talk about it.
100%, it should not be left to you. And this is, and Casey, I want you to sort of either jump on or correct me here, but the thing that kills me about this idea of patient-directed care is it put all of the burden on the patient.
Right, the administrative burden.
Maybe you're caring for a parent and you've got 2 kids in high school and you're working 2 jobs. And by the way, you're sick. Right? Yeah. You do not have time. And what if you work on a checkout? You can't sit there at your desk with the terrible music playing while you do other things.
Right.
That's just not the choices you have. It is going to do nothing other than drive increasing disparities if that's the model we focus on. And I want to go all the way back to Kim, what you were saying, this idea of we need to sort of absolutely re-engineer what it means to deliver healthcare. And I think that's exactly right. And that's where I get quite pointed about the difference between what does it mean to do telehealth, right? To do the odd virtual visit here and there. And what does it mean to build care around the patient and not the clinic? and use a fully integrated healthcare team and use all of the digital tools we have in the toolbox to extend them as far as possible and reach as many people as possible and obviate the need for clinical expertise where we can move it out. So we're using navigators, we're using coaches, we're using all of these sorts of things. And Matthew, and Casey, to some extent, to your point, we are not going to tech our way out of this, right?
Yeah.
Is it transparent? Is it whoever? No, there's not. It's a $4.1 trillion industry. It's bigger than the GDP of France. Would you say, is transcaring going to fix France? Well, of course not. So then how on earth do we think it can fix the healthcare market?
I went to France. It was very good. $100 for my X-ray and my.
I mean, I think that the problem in this, this is a uniquely, always uniquely American problem, is that, because of our mind, the American mindset, we're forced into this lane of the market will solve everything. The market will solve everything, which
no one believes that anymore.
But what?
No one believes that anymore.
Well, I keep hearing it from people though.
Who?
The policymakers,
Who?
Republicans.
I hear
Casey, who's going to solve your problem besides you?
Solve my problem?
Yeah.
So far, the answer to that is me.
That's what I was afraid of.
That's me. But not everybody should have to have a me or be me. It's like I am more than willing, and so was every other patient community leader that I know, more than willing to say, here's how, we've hacked what we need. And here's, the approach that we take to do, to get what we need out of this very fractured system. But the fact that the system is fractured to a degree, we have no control. We just have to figure out how to be able to hack it individually, each one of us on our own. And if we could stop that BS, I'd be very happy. But for the moment, that's kind of where we're stuck.
Is anyone helping you navigate the choices that you're making to try and save your own life? Who do you rely on for that help?
I have access to a vast network of everything from, clinical research brains to, MDs and other clinical types. And, but again, at a certain point, you have to get to a point where you make a decision, you pull the trigger, you go down a path. So, I'm on a path right now, and I do ask questions of a lot of these experts, but then it still is on me, first of all, to figure out if I can get access to that thing they were telling me about. Because there's a whole thing, there's a lot of genomic testing, this one and that one and the other one. So, you need this, you need this, you need, and it's like, well, can I get it? That's the next question. And, but it's on me to go out and do the, make the phone calls, find out, send the email, ask, can I get that? Is this covered? Et cetera. And it just, but that's, I try not to have my entire day taken up with that, because I do still need to keep the lights on here and, still do the work that I've committed to, for actual money that people pay me to do stuff. Right. But, it's a lot. And I'm just me. Luckily, no one else is relying on me. I'm not, as Jen said, the person who's working, 2 kids in high school, right, and working 2 jobs and whatever. The administrative burden on the patient is huge. Right. I feel for the administrative burden of the clinical side, but at the same time, parts of me want to say, well, you fucking signed up for that. Because you got the degree, you got the stethoscope, you got the thing after your name, etc. You signed up for that. I did not sign up for stage 4 cancer, but I got it. So, here we are. And I'm, certainly not the only person with the issue that I have. If I was completely alone, I'd feel very alone, but I'm not. So, but at the same time, it just, I have a good clinical team. They're not the only clinical team, but they're the one I put together. And things seem to be going okay. And as long as I show up for appointments and keep track of what I'm supposed to be doing, then we just keep moving forward. But, everybody's experience is going to be unique because every human is unique. But at the same time, if we could streamline a lot of this, take out the administrative burden on both sides of the stethoscope for a lot of this, it would be lovely. But who's doing that?
Well,
has anyone figured that out yet?
See, that's the market test. If there is a market test here, that's it. Is that if you could rely on an Optum, if you could rely on, where are you? You're in Richmond, right? VCU
Right.
or Bon Secours or whoever it is. If someone was able to step up and fix a lot of the logistical issues, you talk about it. You tell other people about it.
Well, right.
And other people
I very
would want to use it.
I very intentionally assembled a care team at various places, mostly Bon Secours, but there's some other folks. But if you use Epic, I can talk to you. But if you're not using Epic, much as I am not a Judy Faulkner fan, but my life is made much easier by the fact I can do everything here if I need to. Mm-hmm. And, both every time I've been in the hospital, I've been managing my care using this and mm-hmm. keeping track of things and, asking questions and reminding people, by the way, I'm over here in, room XYZ, mm-hmm. and I would really like to leave today, but, so, I ended up in a revolving door hospital fund in August and September. Now my goal is, pretty much uniformly stay out of the slammer. So far, so good.
So Casey, there's a path which is citizen activists, patient activists, put your team together, and you've done obviously an amazing job. And I'm with everyone else. I think okay, I'm being forced into that in a lazy way for my back. It's not as big a deal, obviously, blah blah blah. But I'm wondering as to how do we get it so that that's not a path you have to be forced down? And maybe the way we've talked about this, maybe the way that that Jeff said, maybe why can't we scale IORA, or I had these ridiculous visions of hope for Amazon Cares, which clearly have gone away, or why can't we scale Oak Street, or why doesn't Kaiser get out of this? I mean, Kaiser Canada does this. Why can't it get out of the 9 states it's been stuck in for 48 years or whatever it is? It shouldn't be so hard. And the issue is, I think, two. One is that, institutional, no reason for those institutions to change. No reason for that whatever it is, for the pain management doctors to have anything better than the PDF for me to fill in and send back and hope they'll call me back someday to get an appointment, because they're busy anyway, and so what? And the other thing is no federal policy. I mean, we can argue back and forth, and we have done many times about ACOs and direct contracting and Medicare Advantage. No real federal policy that seems to make it driving the whole of the system to thinking a bit about a holistic view to the patient, what Jen talked about earlier, compared to a policy which pays people in slices of their body. And I love chatting with this. I don't want to talk about data, but Michael, come on, and I see Jen wants to come on as well.
So you heard Casey talk about that her team came from different hospital health systems, right? And so, whose interest is it to help you put together the best possible team? Well, health systems and also insurers, certainly when they buy doctors, they want you to stay within their network of owned kinds of people. The people who have sometimes done this is employers with navigators, depending on what kind of insurance the employer gives you. I mean, it really does come down to some of the economic incentives and a lot of conflicting kinds of things. I did do some research in ACOs, and one of the ACOs that did try to really, manage it was one started by a group of physicians. Their personal money was at stake. And in fact, they recruited partners who they knew, like they had the social ties, and they did not hesitate to kick them out if they didn't play by the rules and really help keep track of the patients. Hospitals, on the other hand, the ACO, this kind of business is a little part of their business. We know most of it's fee for service. We know all the conflicting incentives. And so nobody is going to align the financial incentives for the federal government, because nobody wants that kind of disruption politically of the current thing. They just can't. And they can't even crack down on Medicare Advantage profiteering, because there's too much political clout. So perhaps some of this will scale. And as for the patients, I mean, I'm not trying to be pessimistic, But, Casey, if you were as little as the 99.9%, I would be surprised. Like, I don't know how many decimal points you are on the educated patient scale, but certainly for most patients, one, they're not necessarily in an area where they have the access, but two, they believe more is better. Right? They believe that more care is better care. They believe that getting that MRI.
Well, that's because we've been trained that way.
Of course they have.
As soon as you make something hard to get,
right,
that you have to go through hoops to get.
When you put together what Jeff was talking about, that the DNA of medicine is I'm a specialist and my services are what people need, right? One of my favorite studies is if you ask about treatment for prostate cancer, the radiologists say it's this and the surgeons say it's that. They all, right? They believe, right? It's the enthusiasm hypothesis. So the doctors believe more is better for their specialty. The patients believe more is better. And the payers, the employers got the rear end kicked during managed care. They're not going to do that again. And the federal government, it turns out that every hospital in every congressional district is above average. It's amazing. And so, you have the political things. And one of the promises of the digital health is, in fact, circumventing some of the current system's political and other kinds of inertia in a way that does not raise hackles. And the one-to-many and all the other things that everybody in this group knows about. I wrote, as Jeff knows, 25 years ago about medicine in the information age. 25 years ago in October 1997, right? But the information age is finally allowing some of the barriers to go away, but it is sure slow, because I admit that the one thing I have learned is how much I underestimated clinical inertia. And it's not just younger doctors, because they get the cultural training, and it's not the women. I asked a couple of long COVID women patients whether the women doctors listened to them better than the men doctors. Said no, but their bedside manner was nicer when they didn't listen to me. And so it's the kind of thing that digital health will do is shift the paradigm, because there's a heck of a lot of inertia.
Kim.
So I'm as big a believer in reengineering and tech as anybody, but I wrote an article for Matthew a couple of weeks ago that I'm not going to take any healthcare reform seriously as long as we still have MDs and DOs. We're 120 plus years in this, and we can't decide what a doctor is, what training they should have, and how we tell if they're doing a good job or not. Maintaining both of them is for their purposes, not for patients. And if we can't solve that, none of these other problems are getting fixed. So, we got to go really a step back to the basics about, like, what are we doing here? Who is supposed to be doing it to us? How should they be trained? These artificial distinctions are not helping us. Who
should be licensing them and saying where they can practice, especially
right.
That may all go. There's still
the practice of medicine is for the people that practice medicine. It's not for the people that get the things that they do.
Yeah.
All right, so I do want to change. I want to, with 10 minutes, I want to talk about back surgery, because I know we have some pros and cons here. But let me tell you what I was told this morning, which is something I already knew. A friend of mine who runs a tech company has a bunch of doctors on advisory board. I talked to a very nice, very senior back surgeon in Chicago, and we were discussing, what I had. I showed him my report. Didn't show my film because I haven't got it yet, but I showed him my report. It's all good. And he said, he basically came up and said, you should get a cortisone shot. But if you need it, back surgery works. And I'll tell you about the study. And I knew what he was going to tell me about. He was going to talk about the 2005 sports study, which was run by Dartmouth. And the goal of the Dartmouth study was to show that, like most Dartmouth stuff said, that there was excessive care and it didn't work. And it showed that microdiscectomy, which is the thing which I'm likely to have if I have it, which is when you slice a disc off and stop it hitting the nerve, reduced pain dramatically. But after 2 years, it was about the same process. But if you ask anybody who's got leg pain, do you want to get rid of it now, or do you want to wait and see how physical therapy and gradually get rid of it in 2 years? Mm-hmm. Many people would say they want to get rid of it now. What he didn't know that I'd looked up is there was actually an 8-year follow-up to the sport study, which is quite fascinating, which said that of the people who've been allocated to the surgery group, a bunch of them didn't actually have surgery. So I don't know if the surgery group and the data was on all of them or just the ones who had surgery group. And of the people who've been allocated to the non-surgery group, who theoretically were all better 2 years later, within 8 years, 50% of them had had surgery. Right.
Huh.
So now here's what I really come to. There are two things that have been driving me absolutely batshit. One is that every bit of, you go to HealthWise, you go to the information you've been given from whichever company, whatever, they all say in 6 weeks, 80% of people with my, back pain and leg pain will be better. So I want to say, where is the study this 80% number comes from? And I've been looking and looking. It doesn't exist. And there's some references to some studies done in the 80s. The next thing is the study, right, the sports study that Dartmouth did, 300 patients on either side, kind of some of them floating in and out of the different categories, right, is quite wonderful. Done in 2005, 2006, which is quite a long time ago now. We now have, as Casey said, surveillance capitalism. Facebook, Google, anybody, Christ, Xi Jinping can follow you around, especially for Xi Jinping, can follow anything you do, anywhere you go, on your phone. We're doing about 200,000 microdiscectomies a year, back surgeries a year. And yet we're still relying on a study done of 300 people each side, 15 years ago. Why can I not find this data? And why can we not find the truth? What should I do in the next 6 weeks? I have no idea.
I think this is a hopeless process. You're attempting, I really do.
It is for me in the next 3 weeks. Give me that, Jeff.
You're attempting to interpret, the research literature on your problem by yourself is a fool's freaking errand. And sooner or later, you're going to have to figure out, who do I trust to look at my situation, look at me as a person, and say, what would you do if you were me? And that's the real question. What would you do if you were me? And I'm like, I had back surgery. I was not particularly fond of the idea of having back surgery. I had a 5 vertebra cervical spine fusion in 2017. 5 vertebrae. Wow. And I went to, I was diagnosed here at home. They showed me a picture of my MRI where there were 2 little places in my spinal cord where you could see the little, what do you call them? The restolesthesis, what's the term? Where my spinal cord was being crushed and was dying.
Yeah.
And they basically said, if you don't fix these 2 stenosis, you will be in a wheelchair in 6 months.
Yeah. Ooh, yeah.
I went to a place that has a reputation for not doing back surgery. And they said, you need to have this surgery. And I went there to have it. That's what you're going to have to do. You're going to have to figure out who you can trust with your back and ask them the question, what would you do if this was you? And surgeons don't like being operated on because they know whenever they operate on somebody, something happens to them that has nothing to do with the reason why they were operating on them in the first place. And you end up losing something.
Yeah.
So, I mean, I think this idea of interpreting the literature for yourself it's not a waste of your time. You are a highly rational individual. You know a shit ton about our healthcare system. It's a fool's freaking errand.
Yeah.
I can't disagree. I'm almost doing it out of the joke. Yeah, almost doing the joke for it. And I know in the end, I'm the good news. I seem to be getting slightly better, but I hope I have a fairly uncomplicated situation. But I know
if you haven't read Crooked by Catherine Raymond, you need to read that book.
Sorry, which one?
Crooked.
Why?
Catherine Raymond, Ramin.
Why?
Because she exposes the back industry. I mean, like most surgery, is not valid.
But you're dead right? Most surgery is not. But can I just say of the people who appear on the gang regularly, 2 of them, Jeff and Ian, have both had fusions, right? The things that you say are supposed to be the worst thing, and in both cases, that's worked, right?
Better, and I'm not, and that's an N equals 2. Right.
Not great.
Analyzing from the N equals 2. I mean, Walmart had a Centers of Excellence program for back surgery, and they picked a bunch of places that have reputations for saying you don't need it. Those are the kinds of places that you end up going to.
Yeah, I agree.
Maybe
read the book or read Elizabeth Rosenthal's book. She also talked about back surgery at length.
We know the bad stuff that's going on, right? But then comes down to that basically kind of the individual patient, citizen, activist trying to figure it out. And then, as Jess says, who the hell can you actually trust? And I was, by the way, one of the things that the guy someone said, he said, look, I've done, whatever it's 3,000 microdiscectomies. He said a lot of the people in the Dartmouth study had done like 20. And we know that there's a skill of surgeon, the more surgery they do. And there are so many things that Michael wrote the damn book about this. I don't know why we're still discussing it. It's not part of the process, but we haven't got to the point where there's an easy decision for me to make, because frankly, you can tell me, great, find someone I trust, but I do hang out with a shoulder surgeon who has not returned my email. Bloody Stefano B, I'm coming for you. But everybody else, I like my chiropractor. My primary care doctor's a lovely guy, but I don't think he, really manages. I've got to find a surgeon myself or a person and hope it gets better. Which is, it's not, I'm nowhere near Casey's state, but it's kind of like, well, you don't, Casey. You had to put.
Well, not for nothing, and I'm not saying that this is what's going on with you. You have evidence that it is something else, at least so far. But for 7 months, we chased the issue that
absolutely
turned out to be stage 4 breast cancer recurrence because of where it had manifested. Because I've had back problems in my lumbar spine since since the first time I fell off a surfboard, and then there was the time I broke my neck and didn't know until the next time they thought I broke my neck. That was a horseback riding accident. But, if you look at an x-ray of my spine, it'd be like, dude, I'm like, I know, right? Amazing. I can walk. But, it took 7 months. And finally, my orthopedic surgeon just threw his hands up and said, F it, let's go for an MRI. And that's when they found the Mets in my lumbar spine and right hip and whatever. So I'm not saying that's what's going on with you. But I am saying that, you do need to, my orthopedic surgeon replaced my knee. He has the highest number of procedures in my region. And he also has the lowest complication rate. And that's according to ProPublica's surgeon scorecard. And so, that's why I picked him. And it's proven out because he still calls me every once in a while just to check in and see how I'm doing. He'll show up on my phone. I'm like, dude, you're weird. You call me. You're amazing. But he also referred me to a really good back specialist who was not into the surgery thing. I could, but this was before we figured out what was going on. But it just, you have to just keep pursuing, looking for answers. And sometimes you get an answer and sometimes you just get more questions. So,
All right. So we're almost out of time, but Jen, I think Jeff, and then I'll do a quick round up.
Perfect. But I think there's a delicious irony in this, right? Which is, our ability. I used to work in outcomes research in the department of in a department of surgery at Penn. So, I have deep expertise in making these evaluations. The fact that after decades of very invasive and very expensive procedures, there is absolutely no evidence of when this procedure works and when it doesn't, and our payer is still willing to write the check to have that surgery is an absolute abomination. But there is an irony that this is the case. And we're agonizing over, well, but does virtual mental health care actually help? Should we actually do it? I think that we actually need to take a really long, hard look in the mirror about the different ways that we apply our requests and our approaches and our demands for evidence across the board. I do get really frustrated about how we will pay blindly for traditional approaches to care in an absence of evidence, or sometimes where there is evidence that it's actually not helpful or even damaging. And yet the kind of strategies, Kim, to your point, the way we need to fundamentally retool the health system to make every clinical unit go further and to meet the demands that are vastly outstripping supply right now. But we sit around with consternation and, we couldn't possibly reimburse for this. We don't have evidence that team-based care works, for example. We don't have evidence that a virtual visit is as effective. But we could send Matthew in for $100,000 worth of back surgery when we've just had a really sort of heated debate about, did someone in one of the leading sort of longitudinal studies have a surgery or not? It's ridiculous.
I'd like to believe that we could find institutional solutions to this stuff. But honestly, it really does come down to trust. And if we're not prepared to be the arbiters of the evidence ourselves, we're going to have to decide who we trust, and how is that trust earned? It's earned through a personal relationship, and that's the reason why almost nothing in this system seems to scale, is because we haven't figured out how to transfer that trust to institutions.
All right, that's a fantastic place to leave it. You have been watching and listening, either listening on the podcast or watching on YouTube with to my guests, who were Kim Bellard from the Midwestern Splendor of Cincinnati, Jeff Goldsmith from the farm in rural Western Virginia, Michael Millenson from the hard streets of Chicago, Casey Quinlan all the way from Richmond, Virginia, Jane Goldsack, who is hanging out in some dodgy part of the Caribbean, which hasn't yet floated the WAF yet, called Florida. And I'm Matthew Holt. THCB Gang will be back next week on December the 8th with another calculation. We'll bring you updates on my back, or updates on the World Cup. And hopefully by then we'll have sorted out the entire US healthcare system, but possibly not. And with that, thanks for watching. Thanks for listening to the podcast, and we will see you in a week.